Welcome to the Clinical Anatomy Section 2, which is going to be on the structures of the head and the neck. We'll start with the neck. The skeleton of the neck is formed by the 7 cervical vertebrae in the back, in the front, the manubrium, the very top of the sternum, and then the clavicles, going back from the manubrium to the scapula in the back, and the hyoid bone. The hyoid bone is a floating bone, meaning that it's not connected to any other bones. It has no articulations whatsoever with bones. It's located in the anterior neck at about the level of C3. The hyoid bone is attached to the anterior neck muscles. There are suprahyoid muscles above it and infrahyoid muscles below it. And it helps to, one, form the floor of the mouth or the floor underneath the tongue, and it gives the tongue some stabilization. And then it also helps to keep the airway open. We'll spend some time talking about the fascial layers in the neck. The fascia of the neck can be divided up into the superficial cervical fascia and the deep cervical fascia. The superficial cervical fascia refers to a relatively thin layer of subcutaneous tissue that's located just deep to the dermis and just superficial to the investing layer of the deep cervical fascia. When we look at the superficial cervical fascia, it contains cutaneous nerves, the most superficial vessels and lymph nodes, and then of course lots of subcutaneous fat. Also, when we look in the anterior and lateral regions of the superficial fascia, we see that it contains a muscle called the platysma. The platysma is a really flat sheet of a muscle. It begins at the superior regions of the deltoid muscle and the superficial pectoralis major. It extends over the clavicles and connects up to the mandible, right, the inferior border of the mandible. The platysma is involved in facial expression, specifically kind of bad facial expressions, like pulling the corners of the lips down when you're frowning or kind of disgusted. The platysma is innervated by the facial nerve, which you guys remember is cranial nerve 7. So the superficial fascia is a thin superficial layer. Deep to that is the deep cervical fascia. The deep cervical fascia is a bit more complex, and it's broken up into 3 layers. From the most superficial layer to the deepest layer, they include the investing layer, the pretracheal layer, and then the prevertebral layer. The deep cervical fascia allows for smooth movement of all of the structures in the neck when we're doing things like turning the head or swallowing, where there's a lot of movement involved. All of the structures that are running through the neck can then kind of move and slide alongside each other without causing too much force or damage. They also provide cleavage planes when performing surgery, and they do influence the spread of infection. So as we look through each of these layers, we'll talk a little bit about how it is that they influence the way that an infection will spread or the way that they prevent the spread of infection. The most superficial layer of the deep cervical fascia is the investing layer. The investing layer surrounds the entire neck, deep to the skin and the superficial fascia. At the 4 corners of the neck, the investing layer splits and then comes around to actually enclose 4 muscles. That's why they call it investing, right? It invests or encloses the muscles. The 4 muscles that it encloses are the right and left sternocleidomastoid, and then in the back, the right and left trapezius. Near the mandible, it also encloses the submandibular glands, and it forms a fibrous capsule that surrounds the parotid glands. The investing layer helps to prevent the spread of infection from a superficial abscess. An abscess is just like a cluster of pus, which occurs when there's an infection. So a superficial infection it's prevented from traveling deeper because of this investing layer of the deep cervical fascia. Here you can see the investing layer of the DCF. Looking at it, it's shown in here, on here in red. So notice that, again, it's continuous. It encloses or wraps around the entire neck. And then you can notice how it splits and then comes back together to enclose the four muscles, two in the front and two in the back. And these are the pre-superficial muscles. They're not as superficial as the platysma, but they're the next muscles in. So this is the back, right, or the posterior region. So you see right here, trapezoid, and right here is a trapezoid, enclosed by the investing fascia. And then same thing up here, the sternocleidomastoid, right, originates here at the sternum and the clavicle, hence being called sternocleido. So you can see that the investing fascia splits. Again, right here, you can see the V. It encloses the muscle and then comes back together. Deep to the investing layer of the cervical fascia is the pretracheal layer. The pretracheal layer is located in the anterior trunk only, right, like where the trachea is, and it extends down from the hyoid bone through the superior thoracic aperture and into the thorax. The pretracheal layer ultimately ends up blending with the fibrous pericardium, which, remember, is the thick fibrous layer that's outside of the heart. Posteriorly, so in the back, the pretracheal layer is continuous with the bucopharyngeal fascia, which we'll look at in a second. And then laterally, it extends and it's continuous with the carotid sheaths. The carotid sheaths are tubes that enclose large vessels and nerves on either side of the neck. So the carotid sheath extends all the way from the base of the skull to the root of the neck. And again, it encloses the common carotid artery and the internal carotid artery, the internal jugular vein, the vagus nerve and carotid sinus nerve, and then also sympathetic nerve fibers. So the pretracheal layer is kind of central like this, and then it extends out laterally to form the carotid sheaths. The pretracheal layer has two layers, the muscular layer and then the visceral layer. The muscular layer surrounds the infrahyoid muscles. So we have, again, suprahyoid muscles above the hyoid and infrahyoid muscles below the hyoid. The infrahyoid muscles include the sternohyoid, the omohyoid, sternothyroid, and thyrohyoid. So these are all surrounded by the muscular layer of the pretracheal fascia. The visceral layer surrounds the visceral organs, right? So that would be the trachea and the esophagus that sits right behind it. And then the thyroid gland, which actually we'll see is like a butterfly shape that wraps around the trachea. This is important because if an infection occurs between the investing layer, right, which was the first deep layer, and the visceral pretracheal layer, then the infection can actually spread beyond the neck. The infection can spread down through the superior thoracic aperture and into the thoracic cavity, and the infection will occur anterior to the pericardium. This makes sense because remember we said that this pretracheal layer extends all the way down to the thoracic cavity and it blends into the fibrous pericardium. So if there's an infection that's just outside this pretracheal layer, it makes sense that it can extend down in that space and follow the pretracheal layer all the way down into the thoracic cavity. So this is a big issue, right? Because then we end up having infection right around the pericardium, which is where the heart is. So here you can see that. In green, you see the investing layer that we just looked at before, right? So in green here, this is the investing layer that surrounds the muscles in the four corners. In purple, right? You see the pretracheal layer. So the pretracheal layer here, that is showing us the visceral layer. And then if you can actually see, like see over in these areas, the purple lining, those are the muscular layers. So the muscular layers, again, are surrounding the infrahyoid muscles. The visceral layer is surrounding the thyroid gland, right? So this is the thyroid gland. The trachea, which remember has these C-shaped cartilages. And then behind that is the esophagus. Oh, also the carotid sheaths. Sorry, in red here you can see the carotid sheaths on either side. So you can see how this layer is continuous over here on the sides with the carotid sheaths. The prevertebral layer is the deepest or innermost layer of the deep cervical fascia. The prevertebral layer is a tubular sheath that surrounds the vertebral column and the associated muscles. So real quick, looking over here, this is in orange, right? So you can see the deep layer in orange that's enclosing all of the centralmost structures. In the very center here, you can see the spinal cord. And surrounding the spinal cord, you can see, this is showing you one of the vertebrae. And then, of course, we have all of the muscles that surround the vertebral column. Anteriorly, we have the longus colli and the longus capitis. Laterally, we'll see that we have the scalenes, so the anterior scalene, the middle scalene, and the posterior scalene. And then posteriorly, we have the deep cervical muscles. And you guys will see all of these in lab. The prevertebral layer extends all the way from the base of the cranium down to about the level of T3, the third thoracic vertebra. And at the level of T3, the prevertebral layer ends up being continuous with the anterior longitudinal ligament. So remember when we talked about the vertebral column, that there was that kind of wide, flat ligament that wrapped around the anterior side of all of the vertebrae. So the prevertebral layer extends down and then goes right into that anterior longitudinal ligament. When we look at the prevertebral layer, just anterior to it, there's a space that's called the retropharyngeal space. And this blue arrow right here is pointing to the retropharyngeal space. Okay, so right in this area right here. This retropharyngeal space is important because this is the most common pathway for infection to spread in the neck. So what happens is when there's a pus from an abscess that's posterior to the prevertebral layer, okay, so posterior to the prevertebral layer, somewhere back here, the pus will actually travel over into this region, and a couple different things can happen. It can bulge, right? There can be an abscess and a bulge that protrudes laterally here, right behind the sternocleidomastoid. So you see this is the sternocleidomastoid right here. So laterally, right behind that, we can end up with a bulge from the pus traveling out laterally. Or the pus can actually make its way around to the anterior region, and it can perforate into this retropharyngeal space. A retropharyngeal abscess, right, a collection of pus then in that retropharyngeal space, is a problem because it will push forward or bulge into the pharynx. The pharynx is the throat, right? And all of that is passing through like right here. So right above the esophagus. When the bulge is protruding into the pharynx or the throat, patients will have dysphagia, dysarthria. Dysphagia is difficulty swallowing. Dysarthria is difficulty speaking. Again, this is important because this is the most common pathway for the spread of infection. The retropharyngeal space is the most important space where we see infection spreading in the neck. The neck is divided up into 4 superficial regions. The anterior regions, the sternocleidomastoid region, the lateral regions, and then the posterior regions. These regions are then further divided up into triangles. Just for example, the anterior regions are broken up into submental triangles, submandibular triangles, carotid triangles, like right where you would take your pulse, which is where the common carotid artery passes through, and then muscular triangles on the anterior inferior region. Okay, so there are 4 superficial regions. The regions are further broken up into triangles. We'll start by talking about the sternocleidomastoid region, just because it forms a border or the barrier between the other regions. The sternocleidomastoid region is literally defined by the sternocleidomastoid muscle. So it follows the border or it follows the line that the sternocleidomastoid goes. And the region contains really just the sternocleidomastoid muscle and then the vessels and nerves that pass through it, under it, over it. When we talk about the sternocleidomastoid muscle, remember that it extends from the sternum and the clavicle, right, back to the mastoid process. And the mastoid process is that kind of thick, rather large process that's just inferior and posterior to the ear. The 2 heads of the sternocleidomastoid, right here on the sternum and the clavicle, have a little fossa or depression in between them. And we call that the lesser supraclavicular fossa. Okay, supraclavicular because it's above the clavicle. There is a greater supraclavicular fossa that's just behind that. You go just on the other side of the sternocleidomastoid, and there's the greater fossa is located there. These are important because of the specific vessels that are passing through those areas, and we'll talk about them when we talk about clinical impact towards the end of the lecture. The sternocleidomastoid muscle is innervated by the spinal accessory nerve, which remember is cranial nerve 11, and that's where it gets its motor control from the spinal accessory nerve. C2 and C3 also innervate the sternocleidomastoid, but these are sensory, right? So this is stuff like pain or proprioception, which remember is just like the sensation of position. The sternocleidomastoid, right, the muscle that extends, you can see kind of sticking out right here. The sternocleidomastoid acts as a barrier that separates the anterior region from the lateral region. We see that the external and internal jugular vein will pass through the sternocleidomastoid region. The greater auricular nerve will pass right over the sternocleidomastoid. We'll also see the transverse cervical nerve, all present in the sternocleidomastoid region. The posterior cervical region is another kind of simple one because it's defined by the trapezius muscle. So the trapezius muscle, like if you try and shrug your shoulders up, you can see it raise right there, right? Shrugging it under pressure brings up the sternocleidomastoid. So this descending portion, this top area of the sternocleidomastoid muscle, forms the lateral border of the posterior region. Okay, so from the lateral border of the trapezius back to the midline of the body is the posterior cervical region. The very superior part of the posterior region is referred to as the suboccipital region, right? Which makes sense, right? Underneath the occipital bone. Again, when we talk about clinical impact, we'll talk about this suboccipital region and about the importance of the nerves that pass through this area and being aware of them and not hitting them during surgery. Here we can see these superficial regions. So again, 4 superficial regions, anterior, sternocleidomastoid, lateral, posterior. So those are color-coded. The green is showing you the anterior region in the front. The yellow is showing you the sternocleidomastoid. The blue is showing you the lateral region, and then the pink is showing you the posterior region. You can also see the triangles, right? So the submental triangle underneath the chin, which is referred to as mental, so that makes sense, submental under the chin. The submandibular triangle, it makes sense under the mandible. Your mandible is your lower jaw, so submandibular is right underneath it. The carotid triangle you see right here, again, that's right by where you take your pulse, right? The carotid artery passes right through there. And then again, the muscular triangle. Looking at the sternocleidomastoid, we see a couple different areas here. We just talked about the lesser clavicular fossa. We do have a greater clavicular fossa, which we'll look at on another slide later. Looking at the lateral region, we have the occipital triangle right here, and then the omoclavicular triangle or subclavian triangle right here, which runs under right where the subclavian vein passes through. Again, the posterior region is defined by the trapezius muscle, and we can't really see it here, but we said the suboccipital region is the superior part of this, which is highly important clinically. Torticollis is a condition that it's got multiple different causes, but ultimately it results in some abnormal pairing of the contraction on either side of the neck. So it results in the head twisting, right, the chin twisting to the side, and kind of the face tilting up like this. Congenital torticollis is the most common form, and congenital torticollis occurs when there's a fibrous tumor that develops in the sternocleidomastoid. This develops either before birth or shortly after birth, and what you end up seeing is contraction of one sternocleidomastoid, and that twists the chin away from the contracting sternocleidomastoid, and the other one is not contracting at all, right? So the chin twists and the face tilts up, right, towards the affected side. We can also cause a muscular torticollis if an infant's head is pulled too forcefully during a really difficult birth. This can cause a hematoma to form in the sternocleidomastoid, and then a fibrous mass kind of builds around that area. And if it ends up entrapping one of the branches of cranial nerve 11, it can interfere with the motor innervation to the sternocleidomastoid. Remember that cranial nerve 11 is the spinal accessory nerve, and we said that's the nerve that provides motor signals to the sternocleidomastoid. So if you have a fibrous mass entrapping part of that nerve, you're going to interfere with that motor innervation to one side, one sternocleidomastoid. In this case, sometimes we might need to surgically detach either the sternal head or the clavicular head, or both of the sternocleidomastoid to relieve the tension on the side. Spasmodic torticollis develops in adults, and this can involve multiple or different combinations of the cervical muscles. So it can involve the sternocleidomastoid, it can involve the trapezius, and also another difference. So spasmodic is typically in adulthood, the other two are in childhood, or infants rather. Also, spasmodic torticollis can be bilateral, whereas the other two are unilateral, just on the side where there's damage in the sternocleidomastoid. On the next slide here, you can see an example of congenital torticollis. Here, notice that the chin is pointing away from the contracted sternocleidomastoid, which is really evident right here. Right? You can see that this sternocleidomastoid is contracting, the chin is pointed away from that, and then the head is tilted towards this affected side. Okay, so the face kind of goes up. The lateral cervical region is a bit more complex. There's a lot going on, so we'll spend some time with it. The lateral cervical region, you can see, is bordered by the trapezius, the clavicle, and then the posterior border of the sternocleidomastoid. The lateral region is broken up into two triangles, the occipital triangle and the omonclavicular triangle, or it's also called the subclavian triangle because the subclavian passes through there. You see that it's divided, the lateral region is divided up into the two triangles by the omohyoid muscle, which you see here. The omohyoid has two bellies, right? It comes here and then it comes here. This is the posterior belly back here that cuts right through, dividing the lateral region up into the two triangles. So again, this occipital triangle is right here. It goes up to the occipital region. And then the omonclavicular triangle is between the omohyoid and the clavicle. Deep to the lateral region, it's a group of muscles. So just like deep to this lateral region, underneath the prevertebral fascia, we have the splenius capitis, the levator scapula, the middle scalene, the posterior scalene, and sometimes we'll see just a little tail end of the anterior scalene. Okay, so when we look at this, we'll see a bunch of nerves and vessels passing through, and then you'll see the prevertebral fascia, and then deep to the prevertebral fascia are these muscles. Cranial nerve 11, which is the spinal accessory nerve, passes right through the lateral region. Okay, so you can see it right here. Remember that cranial nerve 11, it's coming out, it ends up innervating the sternocleidomastoid, right? It brings motor fibers to the sternocleidomastoid. And then you'll see that cranial nerve 11 passes out. It goes kind of laterally, inferior laterally, across the lateral region, and then it disappears back behind the trapezius. Okay, kind of down where like the middle third and the inferior third of the trapezius meet. That's where the spinal accessory nerve will go in and enter underneath the trapezius. In the lateral region, we don't see it on this picture, but we'll see it on a picture in a second. We also see the brachial plexus. So the anterior rami of C5, 6, 7, and 8, and T1 all unite, and it's really big, but they all unite to form the brachial plexus. There are three trunks, right? The superior, middle, and inferior trunk that are the brachial plexus, and they're going to pass through the lateral region, and then they exit the lateral region through the cervico-axillary canal. The cervico-axillary canal just refers to the little bit of space that's there between the first rib and the clavicle, and then also kind of the top of the scapula. But it's that small little area that the brachial plexus has to pass through from the lateral region and then to go down into the axilla, and ultimately it's going to go into the arm, right? Brachial meaning arm, and the brachial plexus is providing the innervation to the arm. So here we see both sets of nerves. If you look in this top picture right here, you can see the accessory nerve, the spinal accessory nerve, right, or cranial nerve 11. And that's this nerve that's passing down through the lateral region. And notice the sternocleidomastoid has been cut, right? So the sternocleidomastoid would go like this, right here. So the accessory nerve comes out from underneath it, it goes towards the back, and then it's going to enter underneath the trapezius. The brachial plexus is right here. You can't really see that as well though, as a lot of models represent it. It's relatively big. Looking over here, this picture, we can see the brachial plexus well, right? So I've starred the brachial plexus, and that's what you see right here. So the brachial plexus, you can see on either side, it's going to come and end up going through into the axilla and then the arm. You can also see if you look here, so like the sternocleidomastoid would go here. So this whole area is our lateral triangle. And remember we said that the omohyoid, which goes right here, the omohyoid separates it into the two triangles, right? The occipital triangle is up top. And remember I said that this bottom triangle right here is also called the subclavian because the subclavian vessels. So look here, you can see that really nicely. Here is the subclavian vein. The subclavian artery is back behind that. But the subclavian vein you can see right here, and you see how it passes just beautifully through that subclavian triangle or omoclavicular triangle. There are multiple other nerves that are coming through the lateral region. The suprascapular nerve is coming off of the superior trunk of the brachial plexus. Okay, so remember the brachial plexus is coming from C5, 6, 7, 8, and T1. That's all going to form the brachial plexus, which you can see coming down here, right? And goes through the axilla and into the arm. Up here at the top, you see the suprascapular nerve breaking off, right, above the scapula. And then it's going to end up going around posteriorly, going around to the back, and it ends up innervating the supraspinatus and infraspinatus muscles. So over here, we can see that. First, this is where the brachial plexus is coming on the anterior side. And this is the suprascapular nerve, or part of the suprascapular nerve, that you see going back around the scapula. So if you remember back to your muscles, the supraspinatus and infraspinatus are named because of their orientation with the spine of the scapula. Looking at this, again, is the posterior region of the scapula. This is the spine of the scapula. So the supraspinatus is the muscle above the spine. The infraspinatus is not shown here, but it's the muscle below the spine. So the suprascapular nerve is going to come off of the brachial plexus and then go back around to the back of the scapula. We also see the cervical plexus formed in the lateral region. So the anterior rami of C1 through C4 form the cervical plexus. And the cervical plexus forms what we call the nerve point. They're little loops that are just posterior to the middle of the sternocleidomastoid. Okay, so the sternocleidomastoid forms the border of the lateral region. So if you find the middle of the sternocleidomastoid and go just posterior to that, that's about the level where the nerve point of the neck is. Okay, so the cervical plexus includes all of these kind of nerves that are fraying out from this nerve point. The nerves included we'll see are the lesser occipital, the great auricular, the transverse cervical, the supraclavicular. Okay, so there's nerves kind of fraying out all around from this nerve point of the neck. Just to kind of keep your numbers and bearings in check, remember C5 through 8 and T1, those form the brachial plexus that ends up going to the arm. C1 through C4 forms the cervical plexus that goes to the neck. Here we see the nerve point. So the nerve point, again, is like this region right here. So if the sternocleidomastoid is passing through like this, right, you find the midpoint of the sternocleidomastoid, and directly posterior to that is your nerve point. This is going to be important later when we talk about clinical implications and we talk about anesthetics and where we would provide anesthetics to anesthetize the neck. The nerve point's a good place. So the nerve point again refers to this area right here, and then you can see how you have nerves that are fraying off from there, right, to go to the occipital region. So this is the lesser occipital nerve going back to the occipital region. The great auricular nerve, right? Auricular refers to the ear. So the great auricular nerve is going up towards the ear. The transverse cervical nerve, right, is heading out in a transverse fashion. I don't think, oh yeah, supraclavicular is shown. The supraclavicular nerve comes down right over the clavicle. A nerve block refers to a procedure where we inject local anesthetic in order to block specific nerves going to specific areas. We can do this to anesthetize, right, or block sensation or pain from that area. And we can also do it to paralyze things that are downstream of that area, just depending on what nerve and why we're doing it. If we do a nerve block in the neck, we're injecting local anesthetic for neck procedures to numb the area. Anesthetic is injected near the nerve point of the neck. The nerve point, remember we said, is just behind the sternocleidomastoid in the lateral region of the neck. And different texts give different reference points. So some things say just behind the midpoint of the sternocleidomastoid. Some texts say just behind the junction of the superior third and the middle third, which would be like right here. And you can see the midpoints are kind of right in the middle of those. So locating the sternocleidomastoid, right, and going just behind around the midpoint or a little bit higher, that is where the nerve point is. And remember, we just saw that from the nerve point, nerves fray off in all directions to go to all different regions of the neck and the scalp. So injecting a local anesthetic there is going to have a relatively wide input with just one stick. We can also anesthetize the upper regions of the arm by injecting near the brachial plexus. We inject at the superior midpoint or superior to the midpoint of the clavicle. So finding the clavicle, right, and the midpoint and going just behind that midpoint shows us where the brachial plexus passes down towards the arm. So that's specifically the supraclavicular branch of the brachial plexus, right above the clavicle. And that's going to allow us to do procedures on the upper arm. We can also do a phrenic nerve block, right? And this is to actually paralyze half of the diaphragm. Remember when we look at the phrenic nerves, that the phrenic nerves go down and the left phrenic nerve innervates the left half of the diaphragm, the right phrenic nerve innervates the right half of the diaphragm. So we can block one phrenic nerve and paralyze half of the diaphragm if we're doing some sort of a lung procedure on that half or on that lung. In order to do a phrenic nerve block, the injection site is on the anterior surface of the anterior scalene. So the anterior scalene is just behind and deep to the sternocleidomastoid. So the sternocleidomastoid is a relatively superficial muscle, right? It's deeper than the platysma, but it's relatively superficial. So if you find the sternocleidomastoid and go just posterior to it and down a little bit, right? So right back behind that, we find the anterior scalene. So injecting at the anterior scalene will allow us to do a phrenic nerve block. And again, these aren't blocking the sensory fibers. We're worried about, in this case, we're worried about blocking the motor fibers to paralyze the diaphragm. There are multiple important veins that are present in the lateral region. The retromandibular vein and posterior auricular vein will merge to form the external jugular vein. The external jugular vein is more superficial, obviously, than the internal jugular vein, and it crosses on top of the sternocleidomastoid. Okay, so it goes over the sternocleidomastoid. Later, we'll see that the internal jugular vein goes under the sternocleidomastoid. Okay. So the posterior auricular and retromandibular veins merge to form the external jugular vein. The external jugular vein is going to cross over the top of the sternocleidomastoid as it descends, and it terminates at the subclavian vein. Remember, the subclavian vein is going just over the clavicle. Just above the clavicle, right before the external jugular vein terminates, it has a few other small branches that come join it. The cervical dorsal, suprascapular, and also the anterior jugular vein. Okay, so the anterior jugular vein is relatively small, coming down the front. The external jugular vein is superficial, crossing over the sternocleidomastoid. And in a moment, we'll see that the internal jugular vein is going underneath the sternocleidomastoid, right next to the common carotid. So we said that the external jugular vein terminates at the subclavian vein. This subclavian vein crosses anterior to the anterior scalene and phrenic nerve. Okay, so it's going in towards the midline, across the anterior scalene and across the phrenic nerve, and then it joins with the internal jugular vein. The internal jugular vein coming down and the subclavian vein coming across unite to form the brachiocephalic vein. The brachiocephalic vein is formed just posterior to the midline of the clavicle. Right, so just behind the midline of the clavicle, the internal jugular vein is coming down and it meets up with the subclavian vein that forms the brachiocephalic vein. The brachiocephalic veins are going to unite, and that forms the, on the right side, that forms the superior vena cava. So a few things to kind of keep them apart. The external jugular vein is superficial, right, and it crosses the top of the sternocleidomastoid. It's still underneath the platysma though. The internal jugular vein follows down along the common carotid arteries, and it goes deep to the sternocleidomastoid. The external jugular vein is going to end up terminating at the subclavian, right? And then the internal jugular vein merges with the subclavian, and that gives us the brachiocephalic. Let's look at some of this. On here, I've kind of starred everything that goes along with what we're talking about, but you can see the posterior auricular vein, right? Auricular, like the ear, so behind the ear, posterior auricular vein, and then you can see the retromandibular vein, right? Retro, behind the mandible. They merge, and they give us the external jugular vein. And again, you can see that the external jugular vein is crossing over the top of the sternocleidomastoid. The internal jugular vein is kind of hard to see because it's literally running like right underneath the sternocleidomastoid. But if you look at the sternocleidomastoid, you see like the shadow of it underneath here. Okay, so the internal jugular vein is deep underneath this sternocleidomastoid. The anterior jugular vein, again, is located anteriorly, right here. Remember we said that the external jugular vein is going to go into the subclavian vein, right here. But right before it goes into the subclavian vein, it does have a couple veins that come join it, right? We said the suprascapular vein, the cervical dorsal vein, the anterior jugular vein are all coming over and merging with the external jugular vein. And then the external jugular vein flows into the subclavian. Ultimately, the subclavian is coming in this way, and then the internal jugular vein is coming up down this way, and they merge to form our brachiocephalic vein, right? And we'll have the brachiocephalic coming in like this, and then from the other side, the brachiocephalic will come in, and they'll form the superior vena cava that goes right into the top of the right atrium. Here again, we can kind of see more of the same. So this especially shows us the merging of the large veins at the bottom. So here, this is the subclavian vein, right? In this subclavian vein, you can see this is the external jugular vein right here. And you see where the anterior jugular vein comes in, and then you see the internal jugular vein. And again, remember I told you the internal jugular vein runs right alongside the common carotid artery. So those are deep. The sternocleidomastoid would run on top of those. So internal jugular vein is more deep and it's larger. The external jugular vein is smaller and more external. The anterior jugular vein runs anteriorly and then joins up with the external right before it terminates at the subclavian. So here we see our subclavian, right? And it meets with the internal jugular. And then this right here is the brachiocephalic, right? So here's the left brachiocephalic and then the right brachiocephalic and going into the superior vena cava. Notice that the right brachiocephalic is shorter than the left brachiocephalic. And the reason for that is that, remember, we're heading over to the right side of the heart. So because we're dumping into the right atrium, we've got to get, from the left side over to the right side of the heart. So that's a longer stretch than from the right side of the body. So the left brachiocephalic vein is a little bit longer than the right brachiocephalic vein. We'll look at the arteries that are present in the lateral region. The cervicodorsal trunk is this kind of large one that you see right here, going through the cervical region towards the dorsum, right, or towards the back. The cervicodorsal trunk passes over the anterior scalene, and then it passes over the phrenic nerve. So both of these are showing you roots of the phrenic nerve. So it passes over the phrenic nerve, passes over the anterior scalene. Here you see that it's passing over the brachial plexus. And this is important because it gives off branches that go to the vasa nervosum, of the brachial plexus. You'll see that it branches and gives rise to the dorsal scapular artery, which is this. And the dorsal scapular artery goes down to the rhomboids. And then also more superficial cervical arteries. Eventually, this ends up passing back underneath the trapezius, right alongside cranial nerve 11. Right? Remember, cranial nerve 11 also crosses across the lateral region and it goes deep to the trapezius. The suprascapular artery you guys see down here at the bottom, the suprascapular artery comes and passes laterally, and it goes around the back and supplies the muscles on the back of the scapula, which you see over here. The suprascapular artery, you see, has the vein right next to it, but it also happens to go to the same area that the suprascapular nerve goes. Remember when we looked at the brachial plexus, we said that the suprascapular nerve branches off of the brachial plexus and it goes around to the back of the scapula, right, to go to the supraspinatus and the infraspinatus. So you can see that over here, right? So the suprascapular artery is coming along right next to the suprascapular nerve. The occipital artery branches off the external carotid artery. In a little bit later, we'll look at the carotids, but on the side of the neck, deep, right next to the internal jugular vein, we have a common carotid artery. And the common carotid artery is going to split to an external carotid artery and an internal carotid artery that goes up to the brain. This external carotid artery has a lot of branches. So it ends up, branching off and going, all over in multiple different areas. One of the branches off of the external carotid artery is the occipital artery. So the occipital artery, just like it sounds, supplies the occipital region. So it passes through just the apex, like the very top of the lateral region, and ends up going to the regions of the scalp that lie over the occipital bone. The subclavian artery is on the bottom of the lateral region. The subclavian artery is going to pass over towards the arm, right? And it goes into the axillary artery and ultimately gives blood supply to the arm. Anatomically speaking, the subclavian artery is deeper than the subclavian vein. So the subclavian vein is actually anterior to the anterior scalene, but the subclavian artery lies posterior to the anterior scalene. So the subclavian vein and then the anterior scalene, and underneath that, the subclavian artery, right? So it's like behind and a little bit above the vein. We can feel the pulse of the subclavian artery with deep pressure in the omoclavicular triangle. Remember, so to find the omoclavicular triangle, you turn your head, right, to find your sternocleidomastoid, and it is right back behind, right, where the sternocleidomastoid attaches to the clavicle. So that's the omoclavicular triangle. Putting deep pressure there, I can feel pulsations of the subclavian artery. The subclavian artery can also be utilized to stop bleeding in an arm. As it passes behind the anterior scalene, it comes in contact with the first rib. So it's right up against the first rib. Pushing pressure on the artery against that first rib can control bleeding that's occurring downstream in the arm. So here we see all of this. Just again, I let you guys know that the common carotid artery comes up, right, pretty deep in the neck, and it splits. The internal carotid goes up into the brain, and then the external carotid comes out and has numerous branches. You see the lingual, right? Lingual meaning tongue. You see the facial going to the face. You see the superficial temporal going up to the temple region. And then we mentioned the occipital artery, because the occipital artery is going to pass through the apex. It'll pass through just the apex of the lateral region. Also looking down here, you can see the subclavian artery. The subclavian artery, we said, passes underneath the anterior scalene. It goes underneath the clavicle right here and over the first rib. So as it goes, it's in contact with the first rib right here. That's where pressure can be applied to stop bleeding somewhere downstream here. The subclavian vein, right, would be just like right here. So just in front and below the subclavian artery. The subclavian vein can be used as a puncture site to insert a catheter for a central line. We said that we can use a central line, for example, when we need to infuse large volumes of fluid, which we do when we administer parenteral nutrition, right? When somebody's when somebody cannot eat and we need to give IV nutrition, we do this via a central line. Some medications, especially those that need to be diluted a lot, can go in via a central catheter. We can also use the subclavian vein to measure central venous pressure, which venous pressure is different than arterial pressure. When we puncture the subclavian vein, you can see him doing this right here. You put your index finger in the jugular notch, right at the very top of the manubrium, and then you see his thumb is at the midpoint of the clavicle, right, kind of extending down a little bit. And then if you go beneath the thumb, you should be near the subclavian vein. Okay, the tip of his thumb should be covering up the subclavian artery to prevent puncture of the artery, and going just inferior to that makes it more likely that you'll get into the subclavian vein instead. Concerns here are, one, that you're going to puncture the pleura, right? Remember that just deep to the vessels and then underneath the ribs, we have the pleura. We don't want to puncture and destroy the integrity of the pleura. Also, puncturing of the subclavian artery, which is why he has his thumb placed the way that he does, to try and prevent puncture of the subclavian artery instead. We can look at the side of the neck to try and view the external jugular vein, and we should only be able to see a little bit of it. If the external jugular vein is very prominent, if it's swollen and you can see it really well all along the length of the neck, we call that jugular venous distension, or JVD. This can give us information about overall venous pressure, right? The more pressure in the venous system, the more distended or the more visible the external jugular vein is going to be. Typically, again, we can only see the external jugular vein for a short distance past the clavicle. If you can see it along the whole side of the neck, then that is JVD. That is a distension of the jugular vein. And that indicates, again, that we have increased venous pressure. This is really important in evaluating heart failure. With heart failure, there is increased venous pressure, so we look for JVD. Also, other things that might cause JVD include obstruction of the superior vena cava, right? If there's an obstruction in the superior vena cava, then the blood is not efficiently draining into the heart, and there creates a back pressure, right, or a backlog of blood in the venous system. Enlarged supraclavicular lymph nodes can interfere with blood drainage from the neck and cause JVD, or increased intrathoracic pressure. Same thing, if there's increased intrathoracic pressure, it's harder for the vein to go from this area of low pressure, or the blood to go from an area of low pressure to an area of high pressure. Over here, you can see this is JVD. This is a really distended external jugular vein. Okay, so we finally are done with the lateral region, and we can move on to the anterior cervical region. Remember that the anterior cervical region is the region that is in front of the sternocleidomastoid, right? So underneath the chin area. When we look at the anterior cervical region, we have numerous hyoid muscles that are present. The hyoid muscles attach to the hyoid and stabilize it, or they provide movement of the hyoid and larynx and provide a floor for the mouth. When we look at the hyoid muscles, they're broken up or divided into two groups, the suprahyoid muscles and the infrahyoid muscles. The suprahyoid muscles are above the hyoid. They can connect, they go from the hyoid to the cranium. They form the floor of the mouth and provide a base for the tongue to allow for movements of the tongue, or stabilize movements of the tongue. And then when they contract, they elevate the hyoid and larynx during swallowing and speaking. The infrahyoid muscles are below the hyoid. They stabilize the hyoid bone, the sternum, the clavicle, the scapula, so they provide a lot of stabilization. And then when they contract, they depress the hyoid bone and larynx. So if you think about it, it makes sense. Above the suprahyoid, when they contract, they pull up. When the infrahyoid contract, they pull down. So here we can see the suprahyoid muscles over here and the infrahyoid muscles over here. The digastric, okay, di meaning two, gastric like stomach, so digastric means two bellies. Looking at the digastric, there's an anterior belly right here, and then a posterior belly right here. They're connected at something called the intermediate tendon. And the intermediate tendon forms like a loop over the muscle and connects it to the hyoid bone itself. This where it connects, it's called a fibrous sling, but it allows the muscles to kind of slide back and forth as they contract. Over here in the infrahyoid, we'll see that we also have another muscle that has two bellies. So the digastric, the geniohyoid, mylohyoid is this kind of rather large strap-like muscle, and I have it shown over here as well so that you can actually see, right, how it progresses up from the hyoid bone into like the floor of the mouth underneath the tongue. The stylohyoid, sorry, I kind of colored over it, but it's this yellow one here. Stylo as in the styloid process, and hyoid as in the hyoid bone. Okay, and then again, the posterior belly of the digastric. Over here, we see the infrahyoid muscles, again, below the hyoid bone. So the hyoid bone is shown in white right here. The omohyoid is the one that has two bellies. And the bellies connect at the clavicle via, again, there's a sling. It's called a fascial sling, but again, it's a little connection at the clavicle that allows the muscles to kind of to slide this way and this way as they contract. So the omohyoid comes up here, the superior belly connects to the hyoid, and the inferior belly comes down here and connects to the clavicle. The thyrohyoid, okay, it connects to the thyroid cartilage. So if you look behind this a little bit right here, this is showing you the thyroid cartilage, which is the most anterior, largest cartilage of the larynx. So the thyrohyoid connects to the hyoid bone and to the thyroid cartilage. And then the sternothyroid is a continuation that goes down from the thyroid cartilage to the sternum right here. The common carotid arteries are present in the anterior cervical region. Remember that the common carotid arteries ascend up the neck in the carotid sheath. We also have the internal jugular vein, the vagus nerve, right? They're also present in the carotid sheaths. And the carotid sheaths are the common carotid artery extends up until the superior border of the thyroid cartilage. And then at that point, it's going to branch into the external carotid artery and internal carotid artery. When we look at the common carotid arteries, they have different origins. Okay, so remember that the aorta comes up, there's the aortic arch, and then it descends. And there are three branches off of this aortic arch. The first branch is the brachiocephalic trunk. Then we have the left common carotid. Then we have the left subclavian. This brachiocephalic trunk goes to the right side, and then it's going to split into the subclavian and into the right common carotid. So the right common carotid artery begins at the brachiocephalic trunk. The left common carotid artery begins directly off of the arch of the aorta. And the reason for that is if you think about the position of the aorta, right, it's more to the left of the body. So the left common carotid can just go straight up, but the right common carotid has to get over here to the right side first. So typically there's a brachiocephalic trunk that heads over to the right, and then it splits, and we've got the common carotid that goes up and the subclavian that goes laterally. We typically will take the pulse, or the most common pulse that we take is at this common carotid artery. It's a really heavy pulse, and it can be auscultated just by pressing really lightly in the carotid triangle. This is the radial pulse. The radial pulse is also super common. At the bifurcation of the common carotid artery into the external and internal, right? So the common carotid is going up the neck. At the top of the thyroid cartilage, it splits into the external and internal. Right there, there's this swollen area called the carotid sinus. The carotid sinus has baroreceptors that monitor the pressure in the blood going up, right? So the blood pressure going up towards the brain. Baro meaning pressure, right? So a barometer measures air pressure. These baroreceptors monitor blood pressure. And they want to make sure we have enough pressure to get the blood up to the brain, but not so much that it's going to be damaging. The baroreceptors they're stretch receptors. So they're stimulated by an increase in blood pressure, and then they send those signals up to the cardiac centers in the brain, and then they send signals out to effectors to adjust the blood pressure as needed. Right by this carotid sinus, there's also something called a carotid body. And this mass has chemoreceptors. Chemoreceptors monitor chemicals. So in this case, the partial pressure of oxygen. And if the partial pressure of oxygen goes down, that stimulates these chemoreceptors. They send a signal up to the brain, and then the brain sends a signal down to fix it. In this case, really to increase respirations. That would be the biggest change, would be to increase respiratory rate. The carotid sinus and carotid body are innervated by the carotid branch of the glossopharyngeal nerve, which remember is 9, and the vagus nerve, which is 10. So the common carotid artery, we said, bifurcates and becomes an external carotid artery and an internal carotid artery. The external carotid artery runs up between the mandible, right, and the lobule of the auricular ear. So right here, and it embeds in the parotid gland. And your parotid gland, remember, is right here. So the external carotid artery is coming up, embedding into the parotid gland, and it has numerous branches. At the very end of the external carotid, it divides into the maxillary artery. Okay, your maxilla, remember, is your upper jaw, and the superficial temporal artery. Your temporal bone, remember, is right here by your temple. There are numerous other branches that come before that split. The occipital artery, the occipital artery we already saw going back to the occipital region. The ascending pharyngeal, posterior auricular, the superior thyroid going down to the thyroid gland, the lingual artery we saw going under the tongue, the facial artery extending along the face. So there's a lot of branches that are coming from the external carotid artery, ultimately to go all over the face and the scalp. The internal carotid artery is going to enter the cranium via the carotid canal. So remember when you did the skull and you saw the carotid canal, the passageway through the cranium? The internal carotid artery passes through that carotid canal, and then ultimately it's going to bring blood up into the brain. We'll see how the internal carotid ends up giving us branches in the brain that go all around the circle of Willis, right? We have middle cerebral arteries and anterior cerebral arteries and communicating arteries that are all coming from either the internal carotid artery, or also we'll see the vertebral artery is also going up and feeding the brain. Here we can see most of these arteries. You see the common carotid artery coming up the neck, and the internal carotid artery back here is going to go into the brain. This external carotid artery out here has a bunch of branches. So the lingual artery is coming up under here. Back here you see the posterior auricular artery. You can't see the beginning of it, but you can see the occipital artery back here. The superficial temporal artery is coming up here over the temple. You see the facial artery. So here's the facial artery coming to the face. I think that's everything that we talked about. Yeah. The only veins on here that we haven't really looked at yet, I think, are the thyroid veins. So the superior thyroid veins up top, the middle thyroid veins, and then the inferior thyroid veins are on the bottom, coming from the brachiocephalic veins. Again, the internal jugular veins are going right alongside the common carotid vein. Everything else for the veins we've already seen. You see here the ascending aorta, the aortic arch, the descending aorta. The brachiocephalic trunk is right here, and then that splits into the common carotid artery going up and the subclavian artery going over. And then next, the left common carotid artery just comes straight from the aorta, and then the left subclavian comes straight from the aorta. Right around here is where the common carotid is going to bifurcate, right? Because this is the thyroid cartilage, but we can't really see that bifurcation. We know that the external carotid goes out and the internal carotid goes in. We have multiple nerves that we can see in the anterior cervical region. The hypoglossal nerve, right, cranial nerve 12, is the motor nerve of the tongue, and you can see it here, right? So you see the hypoglossal nerve coming out and innervating the tongue. The glossopharyngeal nerve and vagus nerve, so the glossopharyngeal is 9 and the vagus nerve is 10, are also present in the submandibular triangle. The submandibular triangle and the carotid triangle. So looking over here, the glossopharyngeal and vagus nerves you can see coming down right here. Ouch, I'm sorry. I think that's all we can see there. Okay, we've gotten to some superficial anatomy and then some clinical impact. Superficial anatomy. The sternocleidomastoid is very easy to observe. You guys know that it goes from the manubrium and the clavicle back to the mastoid process. We know that it divides the anterior region from the lateral region. Looking at the sternocleidomastoid, deep to the superior half is where the cervical plexus is, right? Which is why we go just behind there to inject the nerve, the nerve point of the neck. Deep to the inferior half, the internal jugular vein, common carotid artery, and vagus nerve pass in the carotid sheath. To observe the sternocleidomastoid, just have the patient turn their head towards the contralateral side or the opposite side. So if I want to see the right sternocleidomastoid, I'm going to look to the left, right? And you can visualize the sternocleidomastoid relatively well, especially if I tense, passing across, kind of obliquely across the neck. The external jugular vein crosses over the sternocleidomastoid, kind of like an X. Remember, the external jugular vein is above the sternocleidomastoid, the internal is below it. So it crosses over the sternocleidomastoid, kind of like as it goes up towards the angle of the mandible, right? So if I go like that, that's going to cross over my sternocleidomastoid. There, right? Like that's a good position. The external jugular vein typically should only be seen at the bottom here, right in this area. If it is distended, then you'll visualize it better. If you want to distend it, you can do what's called the Valsalva maneuver. This is where you take a deep breath and you kind of bear down, but you guys can kind of see right there that it distends. The jugular notch, you guys know, is at the very top of the manubrium, just medial to the sternal ends of the clavicles. So here, you guys see the sternocleidomastoid comes and connects to the sternal head and the clavicular head. Right in between, or actually we'll look on the next slide. So there we see the sternocleidomastoid. The jugular notch, we said, is just at the top of the manubrium. And here you can see his external jugular vein pretty well, coming right down there. Right, so you can see how it kind of makes an X. The sternocleidomastoid is coming like this, and the external jugular vein is coming like that. So they do cross over each other at the superior edge. There are two fossa right here in relation to the sternocleidomastoid. That lesser supraclavicular fossa, remember, is between the two heads. So you have the two heads of the clavicle, and between them you have this nice little depression. And that little depression that's there is the lesser supraclavicular fossa. This is where the inferior end of the internal jugular vein is. Okay, so the internal jugular vein starts here and it goes up underneath the sternocleidomastoid. The greater supraclavicular fossa is out more laterally than that. So it's back posterior lateral, so behind and kind of outside the sternocleidomastoid. Okay, so the lesser supraclavicular fossa and then go out, that's the greater supraclavicular fossa. In the greater supraclavicular fossa, this is where you can palpate the subclavian artery pulsations. The trapezius was the posterior, the border of the posterior cervical region, and we said in order to see that or make that stand out more, you can have the person shrug their shoulders against resistance. Okay, so you can see that in the back now, right here. I don't have much of a trapezius. So the trapezius here on this guy is pretty obvious, right? Here you can see the border of the trapezius that's starting the posterior region. Also, again, we said that this was our sternocleidomastoid. So this initial fossa, this initial depression that you see right there, is the lesser supraclavicular fossa. And then behind that, right here, you see the greater supraclavicular fossa. The lesser supraclavicular fossa is where the internal jugular vein begins. Okay, so the internal jugular vein begins in here, and then it passes up behind the sternocleidomastoid. The greater supraclavicular fossa is where you can palpate the subclavian artery. Right, so the subclavian artery is passing right here and can be palpated. The occipital triangle refers to the posterior portion of the lateral cervical region. So your lateral cervical region, remember, ends at the trapezius, right? And the posterior triangle of that, the area right here, it kind of comes to an apex at the occipital region, contains the spinal accessory nerve. So this area, you have to be really careful in this area because the spinal accessory nerve happens to be a really common site of iatrogenic damage. This is damage that's caused by some sort of a medical procedure that's happening. So the spinal accessory nerve can be damaged pretty frequently as it passes through the occipital triangle. So you always want to be aware of the course that the nerve is taking as it traverses through. So the way that you find it, the course that the nerve is going to take, is first find the point between the top and middle third of the sternocleidomastoid. Right, so the sternocleidomastoid, find the point between the top and the middle third. Then you find the point between the middle and inferior third of the trapezius. And you draw a line, right, kind of oblique and descending down from the sternocleidomastoid to the trapezius. And that's the course that cranial nerve 11 is going to take. You can palpate submandibular glands and then the submandibular nodes when they're swollen. So the submandibular glands are soft masses that are inferior to the body of the mandible, right? So right here. They're pretty easy to palpate normally, but you can make them stand out more by pushing the tongue against the maxillary incisors. So your incisors are your front teeth. So forcing your tongue against the front teeth makes them stand out even more. The submandibular lymph nodes are lymph nodes that run underneath the mandible, and these can be palpated when they're swollen, so during some sort of infection. So if you just run your fingers along the inferior border of the mandible, that's where you would palpate them. If you continue forward all the way till under the chin, this is where you would palpate the submental nodes, because mental is chin, right? So right underneath the chin are the submental nodes. Here we can see the lymph nodes that are present in the area, and you guys should know all of these. These are important for you to know because you're going to be palpating them, and you'll learn to palpate them and what they correlate with when you go through patho and physical diagnosis. So you at least need to know which ones are where now. We just talked about the submandibular glands that are underneath the body of the mandible and the submental glands that are nodes. The submandibular nodes that are underneath the mandible and the submental nodes that are underneath the chin. The parotid nodes are by the parotid gland right here in front of the inferior border of the ear, and then pre-auricular are in front of the ear, posterior auricular are behind the ear. So literally like draw a line right here, and you've got pre-auricular and posterior auricular. Occipital are a little bit further back and lower. And then there are superficial cervical and deep cervical. Okay, superficial cervical are on the top of the sternocleidomastoid. The deep cervical are lower beneath the inferior 2/3 of the sternocleidomastoid. Posterior cervical are then behind the sternocleidomastoid. So superficial on top of the sternocleidomastoid, go down, deep are underneath the sternocleidomastoid, go behind it, posterior or behind the sternocleidomastoid. And then supraclavicular are above the clavicle, just posterior to the attachment of the sternocleidomastoid. Ligation of the external carotid artery can slow the bleeding from one of its branches. The branches of the external carotid artery are really hard to get to, but the external carotid artery itself is easy to get to in the carotid triangle. So you can ligate the external carotid artery to slow bleeding distally. It doesn't completely stop bleeding because there's collateral circulation. So the facial arteries, the occipital arteries, and arteries of the scalp interconnect with each other on either side. So like the left and right interconnect with each other at the midline. So there is collateral circulation, so you won't completely stop the bleed or the blood flow, but you can slow it a lot by ligating the external carotid artery. The carotid triangle is frequently used as an entry point or a surgical approach to any of the carotids, to the internal jugular vein, the vagus and hypoglossal nerves, to the sympathetic trunk. It's an area that's nice and easy to get into without a lot of overlying tissue. However, you have to be really careful of damaging the vagus or the branch of the vagus nerve, the recurrent laryngeal nerve, as they run through this area. Damage to either of these nerves will end up altering the voice because these are what control or innervate the laryngeal muscles. Atherosclerosis of the internal carotid artery interferes with blood flow to the brain. Remember I said that the internal carotid artery goes up through the carotid canal and delivers blood to a large portion of the brain. So atherosclerosis here ends up causing stenosis or narrowing of the artery, and it can decrease blood flow to the brain. The amount or the severity of the decrease in blood flow depends on the severity of the atherosclerosis, which, remember, gets progressively worse. If there's a partial occlusion of the internal carotid artery, then this can result in something called a transient ischemic attack. Ischemia, remember, is just the decrease in blood flow, and this is transient because it lasts less than 24 hours. It causes focal deficits, so dizziness and disorientation, but again, they last less than 24 hours. And this is a big warning sign that there is a major occlusion happening that needs to be taken care of before it progresses far enough to become a stroke. A stroke occurs when there is a severe occlusion, so there's a big blockage of blood supply to the brain. An endarterectomy is when you open up the artery and literally like scrape it off. You strip back all of the atherosclerotic plaque to try and restore blood flow. This used to be like the go-to, but now we're starting to implement carotid angioplasty, which, remember, was when we brought the balloon in, and the balloon expands and squishes the plaques to the side. And stenting, which is when we put like the nice sleeve in there that keeps the vessel open. These are becoming more popular, and it's just very similar to what we saw when we looked at it in the heart, just in the carotids instead. When we do an endarterectomy, there's a lot of risk of damaging the nerves that pass through in that area. Right, so cranial nerve 9, 10, or its branch, the laryngeal, 11 or 12. The carotid pulse is the pulse that's taken here in the carotid triangle, right at the common carotid artery. We take it just anterior or just in front of the, this is sternocleidomastoid. That's not supposed to say STM. That says SCM. Okay, at the level of this, the superior thyroid cartilage. So remember, the thyroid cartilage is in the front of the larynx, and the superior part of it is where the carotid is going to bifurcate. Okay, so right about at that level is where we take the carotid pulse. An absence of a carotid pulse indicates cardiac arrest. The internal jugular pulse can also be felt. It's felt deep to the, goodness, I did it again, the sternocleidomastoid, above the medial end of the clavicle. So the medial end of the clavicle is where it connects to the sternum, right? So go up the sternocleidomastoid, just above that, and that's where you can feel the internal jugular pulse. In that Trendelenburg position, it can be felt better. This is just when the head is below the feet. Obviously, that's going to increase the pressure in that direction, and that increases the pulse that can be felt. Increases in mitral valve diseases and conditions with increased pulmonary pressure will increase the internal jugular pulse that you can feel. So this is why this would be clinically important, is if there's an increased internal jugular pulse, then you're going to look at issues with the mitral valve or issues with pulmonary pressure or right-sided pressure. The internal jugular vein can be punctured in order to insert a catheter. In order to do this, you palpate the common carotid artery, right? And then just lateral to that, you insert the needle. And the needle is inserted at a 30-degree angle towards the apex of the triangle between the two sternal heads, right? So remember, the two sternal heads have a little fossa between them. So if you insert the needle pointing towards that fossa, right, insert, and then turn the needle down towards the ipsilateral nipple. So ipsilateral is on the same side. Okay, so the needle goes in and then it gets pointed down to go down into or feed into the internal jugular vein.